Hi, I'm Dr. John Nosti, and welcome to Understanding Occlusion. So today, we're going to talk about what defines occlusion. We're going to help you understand when is the existing occlusion problematic, when are forces on teeth the greatest, when does occlusion matter? Like, why is it we're always talking about this is so detailed oriented, but when really does occlusion matter? When should we alter the occlusion on our patients, and how do we perform a CR bite? So if you have had these questions in your practice, strap on in and let's get ready for an hour of fun continuing education. So when we really understand and we look at what defines occlusion, it's important to understand some definitions of occlusion. And I'm sure you have heard the differences between maximum intercuspation or centric occlusion and centric relation. What really are these terms that are thrown out there? I want you to understand these differences between the two, and I want you to understand what determines occlusion in our patients. And what's really important is when and why do we use each of these positions in our practice? So first, the first question we had is, what is occlusion? And if we look at the definition of occlusion, we go back to dental school, we understand that occlusion is the relationship between the mandible and the maxilla when the jaw is closed and the teeth are in contact. This is called maximum intercuspation. And we understand that this position may or may not coincide with centric occlusion. Man, if that isn't confusing right off the bat when we start talking about defining occlusion, I don't know what it is. And if you were anything like me, when I was in dental school and they threw this out there and we said, well, really, they may or may not coincide, centric occlusion. My professor actually said to our group, don't worry about this. You'll learn this after you graduate dental school. Man, that is absolutely unbelievable that here we are in school trying to understand what is simply the most important thing that relates to our practice, how our patients' teeth come together, and they tell us we're not going to learn this until after we graduate dental school. It's pretty crazy. So let's really get in and understand these terminologies. First is centric relation. Centric relation is a clinically determined position. It's where the mandible on both sides placing both condyles into their anterior uppermost position. And really, what is this? This is a joint position. And centric relation is a joint position where the condyles and the discs are in a normal, healthy position. It's important to understand that centric relation is irrespective of tooth contact. So when we talk about centric relation, we're just talking about the joint. We're not talking about anything related to where the teeth come together. That's where centric occlusion comes into place. Now, centric occlusion, in my opinion, is the most misunderstood and misused term in dentistry. If I look on online forums and I see doctors talking about their patients, and I see doctors posting cases, and they say, questions that are thrown out there are, where are you going to restore that patient? And I see doctors commonly say, I'm just going to restore that person in CO. Well, when we really say, I'm just going to, we're pretty much referring to maximum intercuspation, which is the patient's habitual bite. We'll get back to that momentarily, but let's really get into what defines centric occlusion. Centric occlusion is where your teeth meet while your condyles are in centric relation. So centric relation is the jaw joint position. Centric occlusion is where your teeth meet while your condyles are in centric relation. And lastly, we have maximum intercuspation. And that is where all of your teeth are contacting at the end point position, maximally intercuspating, meaning they're all together, but maximum intercuspation may not coincide with centric occlusion. And we'll talk about it, how often it doesn't coincide in our patient's practice. So as you can see here up on this slide, This is centric relation. So here is where we have the bone of the jaw meeting the bone of the skull, and in between there is a disc. How I explain this to my patients, it's much like the disc that lies between the bone of your jaw and the bone of your skull is like the disc between your vertebrae. So we know we want to have a healthy position where that disc lies right in between the two. When that happens, that is centric relation. If the disc is out of position, this could be a problem that we'll talk about later. So you might have heard the term centric relation. If you've looked at Dawson's textbook, which is the most commonly produced textbook in dentistry, especially in your dental schools, you might have heard this called the apex of force position, or you may have seen this called the most superior position. Those terms are interchangeable with one another. They're not made to be confusing you. It's just all interchangeable. So centric relation, most superior position, apex of force position, all of those three are saying the exact same thing. The disc is healthy between the bone of the jaw and the bone of the skull. Now we look at this patient here on the screen. Now this is centric occlusion. This is where the condyles are in centric relation and we have 1, 2, maybe even multiple teeth touching while the condyles are in centric relation. That is centric occlusion. But we can see on this patient, not all of their teeth are fully together. So on this patient, we have a centric occlusion that's different to maximum intercuspation, like we see the patient right here. Same patient. This is all of their teeth together, maximum intercuspation. If we go back one slide, we can see there have some teeth contacting. So there's contact, and then typically there's a hit, meaning teeth touch, and then a slide into maximum intercuspation. So we can see clinically, these are the differences between the two. Centric occlusion, again, maximum intercuspation as that patient slides forward. So now let's talk about some terminologies that you may have heard in order to describe what these contacts are. So we say that if there is a difference between a patient's centric occlusion and their maximum intercuspation, then we say CO, centric occlusion, does not coincide with MI, maximum intercuspation. So they have a discrepancy between CO and MI. That means that there are teeth that contact between CO and MI, and those contacts are called interferences or prematurities. Both of those are used interchangeably with one another. Prematurities mean there is a premature contact preventing CO from equaling MI. So we can also say that, and you may have heard, that person's CR doesn't coincide with MI. That is an okay term to say, but once we're talking about teeth meeting, that CR position becomes CO. That's the same, okay? It's teeth in position while the condyles are in CR. So CR and CO, it's the joint, then it's the teeth. And then we say that there's a prematurity or there's a difference between CO and MI. So those prematurities are premature contacts, teeth touching too soon. So now we know if teeth touch prematurely from centric occlusion to maximum intercuspation, that tooth or teeth must also interfere when that patient goes into excursive movements. Because when we go into excursive movements, we leave maximum intercuspation. So if a tooth touches too soon going to closure, when we leave closure, that tooth must be a prematurity leaving closure. This is important to understand when we talk about why is it really important to understand and change someone's occlusion. So does it make a difference in your patient that interferences exist? That's the most important question. Does it make a difference? that interference exists. So here's what I want you to understand. All of you at home, what I want you to do is sit up straight. I want you to put your head back. And I want you to slowly close until you feel your first tooth or teeth touching. Let's do that together. Slowly close. Once you feel your first tooth or teeth touching, I want you to squeeze. And then I want you to feel that difference. So you at home, if you felt a very slight difference, then you have a small difference, a small discrepancy from centric occlusion to maximum intercuspation. If you felt only 2 teeth touch and you felt your jaw really having to slide forward to get into maximum intercuspation, you have a large discrepancy between centric occlusion and maximum intercuspation. But what I know from fact is that 99% of you who are watching this video, you felt a difference between centric occlusion and maximum intercuspation. For those of you watching who felt no difference between centric occlusion and maximum intercuspation, question I have for you is, have you had orthodontics? Have you been restored in the past? Or have you yourself been equilibrated by a fellow dentist? Important to understand. Let's get back to centric relation, and I'll jump back to understanding these positions and why you may or may not have felt a difference between the two. So centric relation, it is a physiologic position used for reproducibility. It allows us to reproduce the bite each time we try. The temporomandibular joint is not restricted to centric relation in function. So we know this is really not about a functional position because the jaw is freely movable. Understanding that, at the most superior position, the condyle disc assemblies are braced medially. Thus, centric relation is also called the midmost position. A properly aligned condyle disc assembly in centric relation can resist maximum loading by the elevator muscles and show no signs of discomfort. So what I said earlier regarding having the disc lie between the bone of the jaw and the bone of the skull is important for health, because if the disc is out of position, what lies there? We'll talk about that momentarily. So, using centric relation allows for the most repeatable and recordable position, and therefore is only used when designing an appropriate occlusion. What does that mean? We put people there. So for those people who felt no difference between CO and MI, you had your teeth touching, not a big hit and slide. And if you've had orthodontics, restorative dentistry, or been equilibrated, you have been put there by a dentist. For those of you who felt a difference between those two positions, it's because you have yet to be put there by a dentist. But understand, this is not a position that God necessarily wants us to be in or a creator wants us to be in. As some programs have taught, it's a position that we use to put people there in order to restore them for reproducibility, and I'll talk about that momentarily. Let's first understand what determines occlusion. So we have gone through the definitions, but let's understand really what determines occlusion. And there are 3 things that determine occlusion. It is the temporomandibular joint. It is how the bottom teeth, the mandibular teeth, meet up with our top teeth, our maxillary teeth. And lastly, it is the interface between the root and the sockets. So we talked about this earlier, centric relation position, as we see here. We require proper alignment of the TMJ in order to be in centric relation. By definition, the term centric relation is a healthy position of the disc. So the first determinant of occlusion is understanding, is our disc in a normal, healthy position? So I know many of you have had a patient who come in and say, my jaw clicks, my jaw pops, or I hear crackling sound like crepitation. That would be an example of the disc not being in a normal, healthy position. So let's talk about this. We have the articular disc that we can see here is bioconcave. It's highlighted in green on my slide, and it is also indicated with the anterior band as a blue arrow and the posterior band as a blue arrow. The anterior and posterior bands of the disc are thicker than the meniscus or the center of the disc. The center of the disc is where the condyle rests, and the center of the disc is what articulates between the fossa, the skull bone, and the jawbone, the condyle. But if we understand why the TMJ is the first determinant of occlusion, it's because once the disc is out of position, this can affect our patient's occlusion. So if the posterior band moves forward, like we see on the slide here, now in red. So if the posterior band or the disc, we just say, goes from a green to a red position, we can see that posterior band, which is thicker than the meniscus, is going to increase space between the bone of the jaw and the bone of the skull. If we increase space between those two, it is going to drop the condyle down and drop the condyle forward. So let's see what happens to our patients when there is an increase of space between the bone of the jaw and the bone of the skull. You've seen this in your practice. This is Gennady. Gennady comes into my office, and his complaint is that he was playing soccer over the weekend and the ball struck him in the side of the head. And now his complaint is he can't get his back teeth together. So what is happening in order for his bite relationship to change? Well, it could be one of two things, and we have to look at this further. Number one, anytime a trauma happens, you get a bruise on your arm, you get a hit on your leg, whatever it may be, when trauma happens, we get inflammation. We know that as the technical term effusion. Well, inflammation increases space. So just like I showed you on that previous slide, if there's an increase of space in the jaw joint, it's going to drop the condyle down and forward. And when we look at Gennady clinically, we can see here that his back teeth no longer touch. He has an increase of space. It's dropped the condyle down and then dropped the condyle forward. And now, rather than touching predominantly on his back teeth, we can see here clinically on the right side, there's a posterior open space. Now going to the left side, we can see he's hitting on the inclines of the canine and the premolar, but really predominantly, where is he hitting? And if we look at the maxillary teeth here, we can see exactly with articulating paper, he's now touching all the way extremely high in the first couple millimeters of the incisal edges of the anterior teeth. Posterior open bite, contacting extremely high on the anterior teeth. Now, if these become his new interference positions, he can, if he goes without treatment, he can start wearing these teeth. He can move these teeth to try to get his back teeth together, and potentially he could break his teeth to get his back teeth together. But really, rather than understanding what can happen next, I want you to understand how he got here. It is an increase of space in the temporomandibular joint. It is a change in the temporomandibular joint. This is why the TMJ is the first determinant of occlusion. It is the foundation to the house that we are going to build. Let's look at what happens if the disc is lost completely. So we can see here on one side of the screen, going back, we have the normal healthy joint and we have the disc outlined in green. Now, next to this, we have the disc completely out of position. This disc is anteriorly displaced. You might have heard this as termed an anterior disc displacement. If this disc clicks, meaning the patient opens and there's a click present, That is the disc going out of position, patient opens, the disc clicks and comes back in position. That's an anterior disc displacement with reduction. If this disc that we see here out of position remains out of position, that person will no longer click. Don't get hung up on the clicking disc. Just understand the point here of the disc being out of position. That disc occupies a certain amount of space. That disc occupies a vertical dimension. And if we lose vertical dimension in the joint, if we lose that space in the joint, the condyle doesn't go down and forward like increasing space, it goes up and back when we decrease space. And that's what we see here on the arrows. Space is lost between the bone of the jaw and the bone of the skull. Here's where it's really important to give that reference to your patient, or you may understand. What happens if the disc in your vertebrae, that same disc, goes out of position? Your vertebrae start to compress. You can impede on nerves and arterioles and blood supply. You can also have a change in position, and that can affect your posture. It's the same thing with the temporomandibular joint. When the disc comes out of position, that vertical dimension is lost. Now, when the condyle fossa space is decreased, that patient goes up and back. Let's see what that looks like clinically. Here we can see this patient is currently in orthodontics. Their orthodontist referred the patient to me for an evaluation because he had a hard time getting the anterior teeth to couple and getting the midlines to coincide with one another. So we can see from the line on that patient's screen, on that patient's picture, we can see the maxillary midline, yet we can see the mandibular midline is over to the patient's left. Likewise, this person has a overbite relationship that we can see maybe a 1, maybe 2 millimeters of overbite, but we can also see, looking underneath the patient, like in this picture, we can see this patient has an anterior open bite. Now, in my opinion, having the midline discrepancy that we see here, all the way to the left that we can see in this picture, and having that open bite, it's because space is lost between the bone of the jaw and the bone of the skull. The mandible, when space is lost, your condyle goes up and back, your bottom jaw goes back and opens up, and we see an anterior open bite. We can see this rather continuously and very predictably with our patients in our practice. This is Kim. Kim comes to my office, and her chief complaint, she's unhappy with her appearance. Now, this is a very drastic example of what happens when we have changes that are severe in the temporomandibular joint. Here we can see Kim's occlusal position when we use retractors and we look at and analyze her bite relationship. So we can see she as well has a mandibular shift to her left. We can see that the teeth here on the picture, the buccal cusps of the lower premolars and molars, the buccal cusps of the lower posterior teeth are contacting inclines of the maxillary buccal cusps. We can see here on her right side that the lower buccal cusps are contacting either in crossbite or way just initially on the lingual cusp tips. But we should see that mandible right in the middle and the teeth come together. It is also coupled with an anterior open bite. If we look at Kim's mounted models that we see here on the screen, we can see that she's only contacting on her second molars, and she has a segmentally increasing anterior open bite as we move forward. This is not a tongue thrust. In tongue thrust positions, typically all the back teeth are together and only the front teeth are out of position. Here, as we go from back to front, we see an increase of space just like this, okay? Now, if we look at her condyles on a CBCT, we can see that that does not look normal. On a magnetic resonance imaging, which is an MRI, we can see something that's very concerning to us. And in this position, I have outlined where Kim's condyles are, and we know that bone should never be radiolucent. In this picture, her bone is radiolucent. This is a severe case of avascular necrosis. This is both loss of the disc and also a shrinking of the condyle, which is why we see loss of space, and it has created such a discrepancy and such a severe anterior open bite. So we know that the condyle disc assembly, the TMJ, is the first determinant of occlusion. Hopefully with those examples, that has helped you to understand how important it is to understand our patient's joint health. Because if a patient has an unhealthy joint, we can potentially have changes over time to their bite relationship. Extremely important. First determinant of occlusion, the temporomandibular joint. Let's move on to our second determinant of occlusion, and that is how our bottom teeth meet up with our top teeth. And it is that way because the top teeth, the maxilla, it's fixed to your skull. You can't move it. But it's the bottom jaw that's freely movable, and how it meets up with the top teeth is our second determinant of occlusion. So we can see here in this picture, this patient has a discrepancy between CO and MI, just like you may have at home. But is that important to understand? Is that important to change? Do we have to change it? Let's talk about that moving forward. Because as I said earlier, 99% of the population will have a discrepancy between centric occlusion and maximum intercuspation. Our last determinant of occlusion is the periodontal apparatus. And it's important to understand what is the health periodontally of our patients. Because just like the TMJ, which is basically our starting point, our foundation, the periodontal apparatus is our end point. And it's important to understand if the patient has bone loss or morbidities, that occlusion may not be stable long-term either. So it's important. We want to look at the health of the jaw joint, and obviously you're trained to look at the health periodontally of our patients. Now, when I was a young dentist, growing up in continuing education, even in dental school, Dawson's textbook on occlusion is the most commonly utilized textbook in dentistry. And if you look at his textbook, it talks about the definition of occlusal stability. Now, what I was taught as far as the definition, meaning this is a requirement for you to be occlusally stable, I was taught you had to have stable stops on all your teeth while your condyles were in the apex of force position. That is occlusal stability point number 1 that we can see here on the screen. Stable stops just means periodontally, the teeth aren't mobile, and we have to have the condyles in the apex of force position. The next requirement for occlusal stability said we have to have anterior guidance in harmony with the envelope of function. What does that mean? That means when you grind your jaw left, when you slide your jaw right, and you slide your jaw straight forward, only your front teeth touch. That's anterior guidance. None of the back teeth can touch when you go left, right, or forward. Likewise, when you open and close and chew, you cannot bump into your front teeth. That is the envelope of function. So it's a harmony where your anterior teeth touch enough to prevent your back teeth from touching in excursive movements, and not too much that you bump into them when you chew and function. So anterior guidance in harmony with the envelope of function. The next 3 requirements for occlusal stability all refer to the back teeth getting out of the way. So number 3 said when you go slide your jaw straight forward and protrusive, your back teeth don't touch. Number 4 said when you go to the non-working side, so when you grind right or grind left, the opposite side doesn't touch. Or if you go to the working side, meaning the side you're sliding to, your back teeth don't touch. So all that means for 3, 4, and 5 that we see here on the screen, when you slide forward, when you slide left, and you slide right, none of the back teeth touch. And you had to substitute or justify why this wasn't the case. So let's go back to what I said earlier. I said if you have a prematurity to closure, it means you must have a prematurity when you leave closure. Let me rephrase that. If you have a prematurity as you are coming together and your teeth are going into maximum intercuspation, if you slide left, slide right, or slide forward, you will have a prematurity. You will not be, according to this definition, you will not fall into the requirements of occlusal stability. So now you can understand if 99% of your patients come in and they have a discrepancy between centric occlusion and maximum intercuspation, does that mean we have to change 99% of our patients' occlusions? Well, really, according to Dawson's definition of occlusal stability, as it stands, you would have to. So that can become very confusing for new dentists, even dentists learning this out for the first time. It definitely becomes like, wow, I did not do this on a lot of my patients. I've been practicing the wrong way for so many years. What does that mean about me as a dentist? Kind of sounds like I would feel like I'm a little bit of a failure. But really, when we look at it, do we have to change 99% of our patients' occlusions? Is this really what we want to hang our hat on as defines occlusal stability? So when we look at Dawson's definition, if there are interferences, will the occlusion break down? According to his definition, you can have interferences in order to have occlusal stability. So it would mean that if there's not immediate disclusion, will the patient have pain? Meaning if I slide my jaw forward, slide my jaw left, slide my jaw right, will I have pain, being that I have those back teeth touching? Will the occlusion break down over time? And the most important part to understand about these interferences, about these prematurities, is what has to happen for these interferences to become damaging. That is the big question. So with my definition of occlusal stability, I look at it like, what is the first thing I want to see from my patient? I want to see, number one, unworn teeth. I want you to come in, and I don't want to see wear on your teeth. What is my definition of wear? Anytime you have dentin exposure. When you've lost enamel, you don't gain it back, it doesn't grow back, that's a problem. Dentin exposure is the line in the sand that we draw that a problem exists. What's my second determinant of occlusal stability, or my second requirement? I want to have a healthy jaw joint. I just explained to you, having a disc that changes position, a disc that's out of position, having any change in the temporomandibular joint can result in a change in the occlusion. It could mean that we're not stable. So I want to have a healthy jaw joint. That's my second requirement for occlusal stability. My third requirement is to have teeth that are fremitus free. What is fremitus? Fremitus is if I bite down and I tap my teeth, fremitus is teeth that are moving. So if we look at our third determinant of occlusion was the periodontal apparatus, if teeth are moving or vibrating or shifting under force, that's a problem. So we don't want to have fremitus present. We want to have periodontally sound teeth. We talked about that. I think that one's pretty easy to understand. If teeth have bone loss, they can be mobile. That's not a stable environment. We don't want our patients to have muscle pain, having pain in their cheeks, in their masseters, having temporalis pain, pain in their temples. That could be a problem. Patients who come in and report their bite is changing over time is a problem. So one of the requirements for occlusal stability is unchanging occlusions. And really, what is the main thing that we want to be able to do? How was anterior guidance created to begin with? It was to be able to manage parafunction. So when we go back and we look at some questions that I asked you earlier, when is the existing occlusion problematic? When do we say our patients have occlusal instability? When, number one, they have loose teeth. Number two, they have excessive wear, either from attrition, erosion, or abrasion. If our patients have shifting teeth, that is a problem. If they're fracturing cusps or splitting teeth, Those are signs of occlusal instability. Temporomandibular joint breakdown, that's a sign of occlusal instability. Periodontal breakdown, teeth that are sensitive can be signs of occlusal instability. If your patient has a bruxism habit or grinding habit, we call these parafunctional habits, where we start to see signs of wear, breakdown, sensitivity, that is a problem and a sign of occlusal instability. Muscle pain in the masseters temporalis, any one of the elevator muscles, could be initial signs of occlusal instability. And lastly, abfraction lesions or non-carious cervical lesions are another sign of occlusal instability. So I asked you earlier, knowing this, when are the forces on our teeth the greatest? When is tooth contact greatest? Do your teeth touch when you chew and eat your food and you go into function? And if we go into function, are the forces on our teeth extremely high? We know that's not the case. Our teeth only touch in the last little instances of our chewing cycle, and the force on our teeth is not high when we're chewing food. The forces on our teeth are highest under parafunction. So it's not during swallow patterns, it's not during chewing and function, it is during parafunction. That is when we put the most force on our teeth. When do we go into that lateral excursive movement? When do you touch your teeth and slide forward? When do you touch your teeth and slide left? When do you touch your teeth or slide right? That's not during function. You don't chew that way. That is a parafunctional movement. Anterior guidance was designed in order to try to manage parafunction. It is the first step in parafunctional control. It is a night guard you cannot take out of your mouth. So, when does occlusion matter? So if we know that we don't touch our teeth when we chew, we know that it's under parafunction, that's the big concern. Then the next questions is, when does occlusion matter and when will we alter the occlusion? Great questions. This is when I use CR in my private practice. If a patient comes in and shows signs of occlusal instability, so if I see the existing occlusion is not working for them, or they have a parafunctional habit, we want to rebuild that occlusion to a position that's reproducible and optimizes the forces on the teeth, that is when I would use CR or use centric occlusion position. If I'm going to perform a study model analysis, like we see here right on my tabletop, or if I'm going to sit down and analyze that patient's bite, I want to start from a reproducible position, which is centric relation. So anytime I'm doing diagnostic records, I'm going to take that from a centric relation position. If I'm treatment planning a patient, I'm going to start from a centric relation position. Diagnostic wax-ups is a centric relation position. I think you can start to get the gist of what I'm saying here. If I'm changing vertical dimension, I'm going to start from a centric relation position. And really being able to open vertical dimension predictably is with a centric relation bite. Most importantly, in summary, if I'm doing more than 3 units of indirect dentistry, I'm going to analyze where that patient's centric occlusion position is, and I'm going to get centric occlusion and maximum intercuspation to coincide with one another. So really, when you look at any one of these lists up on the screen, if I'm taking more of a risk in putting a lot of dentistry in my patient's mouth, meaning I'm doing more than 3 units of indirect dentistry, I'm going to build it, I'm going to change that patient's occlusion. This way, I can build them in a parafunctionally best environment. I can build them from a protective environment, and I can get them into anterior guidance. I'm going to get rid of those interferences. That's really what it means to treat someone to centric occlusion, or to get centric occlusion and maximum intercuspation to be the same. I'm going to get rid of those interferences, and this is when I do it in my practice. Also, if I'm going to give that person a splint construction. If I'm going to give them any type of parafunctional appliance, it's going to be in centric relation. If I'm going to build their anterior guidance, it's going to be in centric relation, such as full mouth reconstructions, just beyond 3 units of indirect dentistry. A full mouth reconstruction is absolutely more than 3 units of indirect dentistry. Dentures. A denture is a removable full mouth reconstruction, and I'm going to build that patient into a centric relation position. And really, as I said earlier, it allows me to manage parafunction. Any periodontal patient who's got mobilities, I think it's a great idea to equilibrate that patient to harmonize the forces on their teeth. And we do that from a centric relation position. So why? Let's bring this around. When a posterior tooth is in an interference, it's a prematurity to closure. It has to be a prematurity in an excursive movement. So as the person grinds left and grinds right, you have a back tooth and a front tooth that are touching simultaneously in excursions if your CO and MI do not coincide with one another. So anytime a back tooth touches, we know muscle force is high. The muscle contraction rate is increased. So when you're grinding left and grinding right, if back teeth are touching the same time front teeth are touching, your muscle force is high, you don't have anterior guidance. That can become a problem. So this means that anytime a back tooth is touching simultaneously as a front tooth, that back tooth force, that high force is going to be put onto your front tooth. It's going to allow you to wear your front tooth. It's going to increase the shearing forces on your front tooth, potentially creating wear rates, fractures, if there's porcelain present on the front teeth, if there's bondings present on the front teeth. It can cause any type of failure of an anterior restoration when that person goes into that excursive movement. So when we have anterior guidance and only the front teeth touch, muscle force from the elevator muscles shuts down, meaning that we now have a more harmonious force relationship on our teeth, and it allows the forces to be cut down. It allows our front teeth not to be subject to those back teeth forces. It shuts the elevator muscle rates down. It is better, it is a healthier position than we have it if we don't have anterior guidance. So, a little bit in summary. Maximum intercuspation, that's the patient's habitual bite. And do I do this and do I use the patient's habitual bite every day in dentistry? Absolutely. Where would I use it? If I'm only doing a single tooth or everyday dentistry, 1 tooth, maybe even 2 teeth. If I'm doing direct restorations, I use that patient's habitual bite. Why? Because it's easy for me and easy for you, and I know you've been doing this at home, to get the dots and the lines to match up on 1 or 2 teeth. There's not a whole lot of risk in the system when you're restoring 1 or 2 teeth. So anytime I'm providing care less than 3 units of indirect dentistry, I'm just going to use that patient's habitual bite. Where else do I use it? If my patient currently is occlusally stable, if they don't have signs and symptoms of occlusal instability, I'm going to use that patient's habitual bite. Why? Because the majority of our patients are not in centric relation anyway. So why change their bite if we don't have to? If they show no signs of instability, we're only going to do 1 or 2 teeth on them. Why change that patient's occlusion and go through all that dentistry? There's no reason to. Let's talk about taking a centric relation bite. This could be very easy in our practice. A simple tool that I use and have taught my assistants and many dentists across the country what to use in their practice, it's called a leaf gauge. A leaf gauge is very inexpensive. It allows us to change the vertical dimension on it so we can separate back teeth. And really what we're going for is just enough leaves in place that we can see here to separate all of the back teeth. That's the goal of a centric relation bite. We want to get the back teeth out of the way. We want to be able to seat the condyles. We want to take a bite relationship when the condyles are seated irrespective of tooth contact. Remember, that's the definition of centric relation. And I'll let you know what we're going to do with this in a minute. So I want to make sure we have minimal leaves in place to get the back teeth out of the way. It's a good idea to confirm with articulating paper that no back teeth are touching. I don't like asking my patients, do you feel your back teeth touching here? Because quite often they will have teeth touching, but the proprioception is so limited, they can't tell their teeth are in contact. So it's a good idea to confirm it with articulating paper. This is fast, it's efficient, it's cost effective. You can have multiple of them in your practice, and it really allows the patient to move both in protrusive and slide back. And that's what I have my patient do. I put the leaf gauge in place. Many times when you put something between patients' front teeth, they go to bite on it. So they will be in protrusive. So welcome that, have them slide forward, then say slide back and squeeze on your back teeth. And they'll slide back on the leaf gauge and they'll squeeze, and typically the elevator muscles take over and they will seat the condyle. So it really allows you to do this. For a video technique tutorial on this, you can go to YouTube Clinical Mastery Series and look up silicone centric relation bite record. So here is it in place. Leaf gauge in the front. I use Futar D by Kettenbach Dentistry. This is an extremely hard bite registration material. It doesn't provide any give, which is really important because we're going to mount these models on an articulator, on a chewing simulator. Leaf gauge up front, Futar D in the back on both sides. Patient squeezes until that sets. You then take the leaf gauge out and just tripod the front. Do not join these three pieces together. They're three separate pieces, and that goes to my lab to be mounted. Many of you might have become familiar with a elucid. This is a pretty good technique. It has a whale's tail, which is that metal portion that we see there, and an anterior jig. And you put a little bite registration material on that anterior jig, put the whale's tail in place. That seats the anterior jig. Once that's set, you can take that out and the patient bites on the elucid jig. The only problem I have with the elucid jig is I can't change the vertical dimension on this. So if I want to alter the vertical, it's pretty difficult to. And in my opinion, this person is just a little over opened, and I would like to lower that down, which is why I like a leaf gauge better. It also requires a little bit of time to place it, and it's not as cost effective as a leaf gauge, which is reusable. So that's why I really like a leaf gauge. So then what am I going to do with this? Well, with this information of having a centric relation bite, I can take that bite registration, I can take three-dimensional blueprints of the patient's models or teeth, right, either with a scan or with impressions, and I can mount it on a chewing simulator. And once in place, I can close the articulator down and I can see exactly where their initial teeth touch, and then I can see where their endpoint position is or maximum intercuspation. It allows me to analyze that on models, make any changes that I want to on models before I bring that to the patient's mouth. So I hope you've enjoyed the last 45 minutes together, and I hope this video really helped you understand more about occlusion, what the definitions are, when you want to change it, and why you'd want to change this. And hopefully you got a good feel for how we at CMS love to empower our docs who take our courses. I would love to personally invite you to our Ultimate Occlusion series. It is a 4-part series that teaches you everything from single tooth dentistry to cosmetic constructions to full mouth reconstructions, both on natural teeth and utilizing implants. It is a series designed to get you to really understand and absolutely be able to perform these cases in your practice. I look forward to seeing you at the next Clinical Mastery course.